Good afternoon. Nobody's feeling drowsy, are they, after that big lunch? My name is Mary Bissell. I'm a partner with Child Focus, which is a national consulting firm that works on child welfare policy issues. We're based in D.C. and Providence, Rhode Island. And I'm very, very happy to be here with our distinguished panel today. As technology addresses the questions of how people and systems can talk to each other more quickly and more efficiently than ever before, there's another more interesting and complex set of questions that comes up. And that is, should there be limits on what those people and those systems can say to one another? And what should those limits be? It was interesting to hear Dr. Hunt talk today about how privacy, when you look at how Maslow's hierarchy impacts IT implementation, how privacy was the base of that pyramid. And so this afternoon's discussion is at heart really a discussion about boundaries and how we set those systemic, legal, personal boundaries around the exchange of information. But as all of you know, the reality is that unlike new technological developments, the process of setting those boundaries around privacy can be anything but rational. So let me give you an example. I was at the Toys R Us Christmas shopping in the last 3 weeks or so, and there was a huge long line. I get up to the beginning of the line, and the first thing that the clerk says to me is, "Phone number, please." At that moment, that question triggers, I turn into my grandmother, who was actually quite imperious with any kind of store clerks. And I said, "I would just prefer not to share my number with you today." And then I proceeded to give her my credit card and charge all of the items that I was trying to buy, which, of course, gives her company and the technology that they have, my age, the ages of my children, the type of products I was buying, my phone number, my email address, all of those things. Today we're going to explore these inherent contradictions, what the boundaries are and what our perceptions of those boundaries are. And we have a wonderful panel to help do that. We're going to begin with a comprehensive national overview of this balancing act between information sharing and privacy and its legal implications with Jennifer Cox. Jennifer is a member of the Hartford-based law firm of Cox and Oswicki, where her practice is focused on the healthcare industry. She's a frequent lecturer on provider and patient rights, healthcare information management, and operational practice issues. She's going to be followed by Elizabeth Laird, who is the program manager at the Data Quality Campaign, which is an organization that focuses on supporting the role of longitudinal educational data in instruction, management, and policy decisions. Among other issues, Elizabeth manages the analysis of connecting state and district data systems and linking longitudinal education data with other information systems as well. In addition to looking at the implications of confidentiality on the national level, we're also going to be exploring information exchange on the state and county levels, the front lines. And to spearhead that discussion, we are pleased to start with Don Will, who is manager at the California Administrative Office of the Courts at the Center for Families, Children, and the Courts. In that capacity, he oversees the California Court Improvement Program, which includes several projects that are focused on data interchange between the courts and the California Department of Social Services. We also have Uma Ahluwalia, who is here to share her experiences on the front lines as the director of the Montgomery County, Maryland Department of Health and Human Services. With 1,600 employees and a budget of more than $265 million, the department is one of the largest in Maryland and includes aging and disability services, behavioral health, crisis services, and children, youth, and family services. And last but not least, and we're going to hear from Jone actually after the break, we have Jone Bosworth. She's not only our last speaker, but played an instrumental role in putting this panel together, and you'll see the article that she put in the background information in your packet. An attorney and president of Ready Impact Strategies, a St. Louis-based management company, Jone has led strongly consumer-focused public sector departments in 3 states in the areas of child welfare, juvenile justice, children's mental health, and early childhood education. So before I turn it over to the speakers, I just want to give you just a little overview of how we're going to divide this afternoon. Once we hear from our first 4 panelists, we're going to have a brief break, let you get some caffeine, and tend to Maslow's hierarchy. After you come back to the break, we'll hear from Jone, and then we're going to break into individual discussion groups so that we can discuss some of the themes that we've heard this afternoon. And Gretchen Prasanna will set those up for us. So with no further ado, I'm going to turn it over to Jennifer.
Thank you, Mary. What I am here to do today for you is to go through the changes to HIPAA that come about as part of the Stimulus Act and through what's called the HITECH Act. And this is really just to touch on the words, so when you hear or you read, well, that changed, you'll have an idea of what the heck we're talking about, because it's pretty complicated stuff. So here is the overview. I think you know the Health Insurance Portability and Accountability Act of 1996 was passed by Congress. And in that, we go back to the basics because I think we have forgotten a little bit of how this works. In that, it was required that Health and Human Services come up with rules for privacy, security, transactions code set, and other things they haven't even got to yet. It's 1996. And to put those rules out. If they didn't do it by a certain date, if Congress didn't do it, then HHS would do it, which is what happened. We have what's called, we now call it the Privacy Rule, which went into effect in 2003. April 2003, we are now almost 7 years out from a rule that is performed properly by about 15% of the people to whom it applies. That's not a good sign. The Security Rule, which is the electronic flow of information rule, went into effect in 2005 with a rule that was written in 1998. Written in 1998 in technical speak that is so far behind us now that it almost does not make sense. I also started after my graduate work at an office. We did not have computers on our desks. You were lucky if you could borrow the dictaphone from the person next to you and somebody typed stuff up. And when I talk to young lawyers now, they say, why don't you just look it up? I can just look it up now, but then there were actually books that had pages and things you looked at. And so those rules are actually written at a time in the mid-'80s where the technology we have now is entirely foreign. So these rules don't fit a lot of the time, which is part of what causes the tension on why it doesn't always work well. And here today, we're going to talk about what has changed in the high-tech rules for privacy and security. The trick to that is you'd have to know all the rules first to understand why the changes are important. And again, every single self-report indicates that about 15%, 15% of healthcare providers are 100% HIPAA compliant by their own admission. Not a good sign for moving forward. Who is covered by HIPAA? This gets confusing, and again, it's something we need to go back to the basics for. HIPAA covers, that is to say, we're talking about privacy and security rule. HIPAA covers health plans. That includes Medicare, Medicaid programs, but it does not include all government payer health programs, but most of them. It includes private health insurers, what we used to call HMOs, we now call MCOs, managed care organizations. And it also includes self-insured plans, so large employers often have self-insured plans. It's basically, in addition to Medicare, Medicaid, anything that ERISA would cover is who it covers. It also covers healthcare providers who submit electronic transactions. This will be important in a second. So it's not all healthcare providers. It's just folks who bill electronically using what's called standard transaction format code set. That's fun, which is most people. But there are pockets that do not do this. The easiest example is adolescent mental health care. That is often not covered on a lot of plans. Parity hasn't reached that for, say, eating disorders or some subspecialty. Those folks take a check or you don't get care, so they're not in the system. So there are pockets, particularly to mental health specialization in high-end areas, that HIPAA doesn't reach because they do not submit billing electronically. That's actually how it hooks in. Why is that? Fascinating, actually. It's that way. I could talk about this all day. It's because you use the internet to submit the bill. When this went through in 1996, there was a whole lot of chatter, which is now water under the bridge, but a whole lot of chatter that this was unconstitutional. How could Congress reach in and make the various states do something with health care, which is generally known to be a state-by-state regulatory process? The answer is, if you use the internet, federal government grabs you. So you use the internet to bill, you're in HIPAA, you're off to the races. That's how they did that. And that's a fascinating thing that is going to come up again. I think you see, if you read any major newspaper, the 60,000-foot view of high tech and how it's going to work, or the new healthcare reform bill. There are going to be constitutional challenges based on these same issues, and we've been through these issues, so we sort of know where they're going to land. In addition to plans and providers who bill electronically, it applies to something called healthcare clearinghouses, which really means third-party billing services, folks who come in and put your information in a format to send the billing from their office to get paid. HITECH creates an immediate change to this. They have added personal health system vendors. So Walmart and the big drug companies went and made personal health systems, which weren't in HIPAA because they are not any of those other three things, and brought them into this world because we need everybody who's got health information to be at least at the same base level. There's a natural tension, and this has been the theme I think will be for this entire conference, between protecting privacy and patient rights and the sharing of information. Those two things are actually opposed in a lot of ways. So HITECH creates another challenge because on the one hand, HITECH gives a lot of financial incentives for upgrading electronic health records, electronic medical records for healthcare providers. At the same time, it's got these HIPAA changes, which are a stick if you do it wrong. So you've got, here's some money to upgrade, here's a stick if you do it wrong, and it's making healthcare providers extremely nervous. So the good aspects of sharing, I think, are fairly well known and obvious. We coordinate care better. We improve quality, we improve safety, we improve research, we reduce costs, we promote interagency sharing. Those are all great things. The negative aspect, and it comes right through when you try to put these things into place, patient privacy is naturally reduced, good, bad, or indifferent, every time you increase the flow of information in healthcare. It's just how it is. It's important to keep in mind that there are other things that play into privacy, confidentiality, and the tension of sharing. For example, and so it was already referenced today, substance abuse laws. 42 CFR Part 2 are the SAMHSA laws that create a very specific protection for substance abuse laws. We went out of our way as a healthcare industry to integrate substance abuse, behavioral health, mental health, and physical health records, and now we've got a record we can't share because it's got this one little part in it that doesn't work. So there was sort of a system malfunction there. FERPA, which is the educational protection. Educational records are protected, not HIPAA. There's a whole set of labor and employment laws, workers' comp laws that are not HIPAA, that all have their own silos that are not brought into this system and, in fact, have entirely different rules. So for a healthcare provider who touches on all these things ends up getting stopped at different places. We still don't have a cogent way to look at information because we're siloing it per different federal and then state laws. State laws still, 50 states get to make up their own health laws, and they do. And HIPAA creates a floor, but it doesn't create a true sharing of information or even a good answer to how you use information within a given state. And then there's another thing that a lot of folks forget. For providers, there's a lot of ethical rules on top of that. A lot of things you can and can't say, should or shouldn't do, that don't always jive properly with the state, federal law, or HIPAA. The easy example is the American Psychiatric Society has a lot of specific rules on what you should share, with whom you speak. Those also play into how information is going to be shared. It's important, HIPAA versus FERPA comes up a lot, and it's very complicated, and part of the reason it's complicated is it doesn't actually make any sense. FERPA was here first, and FERPA is important to understand that it is the thing that is going to be for school records, whether they're medical, whether they're tests, whatever it is. FERPA is going to trump HIPAA. It was there first, so they built HIPAA around it for all intents and purposes. And even if you have a medical record, if the school or the entity that is making the record is a FERPA-regulated entity, it's not HIPAA. It's just a trump card that's in the rule. It's just how it is. Logic doesn't make any difference. The only time HIPAA would apply in a school situation is you're not FERPA. For example, you're a private school that does not have any other students that are there as a FERPA activity. You don't take federal funds, and you are a healthcare provider that bills electronically, which is incredibly unlikely for a school. They are not submitting that transaction we talked about for billing in order to go into HIPAA, so they're actually nothing. They're not FERPA, they're not HIPAA. They might have state laws where they are for the exchange of information, but they don't fall into any federal scheme. So why is there so much confusion about FERPA HIPAA? We do an all day trying to separate for the school providers versus pediatric providers what they don't have to do and don't have to do, FERPA versus HIPAA. The reason I think is because HIPAA is the thing people hear the most about. Unless you truly are in education, your mother, your golf partner, these people do not know anything about FERPA. They know about HIPAA. They read it in the New York Times all the time, but nobody talks about FERPA, which was there first, is still there, needs to stay there for various reasons. But we misconstrue things because we're always jumping to the HIPAA rule, which when you're in education is not it. Common sense doesn't help you because it's just a rule. so try to avoid thinking about it too hard because it will get confusing. So when you focus on it, focus on the gatekeeper. So if you're at a school-based setting that's FERPA, you're in FERPA for almost, I'd say 98% of the time. It's very hard to drag yourself into HIPAA. So the example is problematic. What happens when you have FERPA and HIPAA collide, which happens every day? School nurse who is a treater, so that's a thing in HIPAA, but not a covered entity in HIPAA who has to do HIPAA, has to talk to the pediatrician. Sometimes they can have a conversation. It's permitted by HIPAA, and sometimes they can't because the pediatrician's still doing HIPAA at her office, even if the school nurse is doing FERPA at his office. You see the problem? So in this example, if the school nurse needs immunization records for a treatment discussion, that information can flow under both FERPA and HIPAA. But if the school nurse wants it because they're filling out forms and they're moving their cabinets and they're updating their forms, it's an administrative issue that is not a treatment issue, HIPAA does not permit the doctor to say what's going to happen without an authorization from the parents. So you see that there's about 100 of those we could give you, tiny things that stop the flow of information for almost no good reason, except that they're actually different systems that sound the same. So here are the specific high-tech changes. This is the overview slide. The big change is something called the breach rule. HIPAA privacy has, I'll just come out and say it, even though I'm a provider-side attorney, not been enforced well, which has led to what we call HIPAA slide. No one's really doing it. They don't do it well. They know they're not doing it well. In healthcare with scarce dollars, particularly, it's mostly not-for-profit on the hospital side. In this part of the country, it's almost all not-for-profit on the hospital side. What gets measured gets done. This isn't getting measured. There were 17,000 HIPAA privacy reported violation and complaints since the rule went into effect in 2003. I know you feel it coming because it's a trick question. How many fines? 0. 17,000? 0. So the hospital stopped paying attention to it. It's not that they don't want to, it's that they have other things to do. So they came out with something called the breach rule in high tech. And its concomitant regulations, which are still, they're only an interim final, not final, which also makes hospitals do nothing until it's final, where you now self-report every HIPAA privacy violation you do. Well, this has their attention, and it's all providers who are HIPAA covered entities and their business associates, which is everybody who works with them. This is like going from 0 to 60 in no time. It would have been nice if they just enforced it at all, but they jumped to using nuclear weapons to kill mosquitoes. So here we are. Starting February 21st, 2010, which is now, for all intents and purposes, all covered entities and their business associates must self-report every HIPAA privacy breach. There's a little matrix to do it, but it's just what it sounds like. It's reporting to the patients and to the government and keeping a log and all other kinds of stuff. They're not ready. They're petrified. And this, again, is just coming right out of the box really fast. There are then about 15 other privacy changes that are tightening up things that would have been this way if the Clinton administration rule had stayed the same, but it got changed when the Bush administration came in because that's when the rule went final between those two. And then there are ridiculously higher new enforcement rules. Again, it would have been nice if they had enforced the rules they had instead of quadrupling them and then say they're going to enforce them, which we have every reason to believe they are. Another huge change in high tech for HIPAA. Business associates, which are the folks who aren't healthcare providers or plans, but they do something with the protected health information for them, they're their vendors, they have to do what's called the security rule fully. They used to just sort of say, thumbs up, I do that. Now they actually have to do it, which they're finding out is an incredibly expensive, difficult thing, and the ones that found out. Others will find out on February 18th when they get a letter saying, I can't do business with you anymore because you're not compliant with security rule, which is not, the education component from the government's not coming out fast enough for anyone to know what's happening. Breach rule. So the breach rule that I talked about fundamentally changes how HIPAA is. This is a shocking change, perhaps as big as HIPAA itself in the privacy rule. That starting on February 21st, you do your own self-reporting to the patient, to the government. This is an entirely different perspective than providers have had, and they are way behind on being compliant, and there's not enough time to be compliant. So it's going to be an interesting discomfort, I think, when there's violation after violation and it's in the newspaper and everyone knows it. It's probably going to have the immediate effect of disquieting patients and consumers because it's going to look like it's a disaster, which is what it's going to look like. Significant administrative updates are still coming. HHS cannot keep up. It's just not physically possible to keep up with the number of rules they're required to write out of the Stimulus Act regarding this, so they just keep coming out with them. over and over again. The only people that's good for are me, perhaps Jone, because we get paid to read it and tell people what it means over and over and over again, because that's what's happening. And it uncovers an existing flaw. HIPAA was not being followed well for years. So we've now uncovered the flaw, and there was no negotiation. We're moving right to the penalty phase. Here are the other things it does, just sort of randomly, to a large degree, that change. Again, repeating this concept, though, HIPAA privacy is both an access rule, that is to say, allowing consumers and patients access to their information. At the same time, it's a confidentiality protection rule. Providers tend to get stuck in a mindset of the protection side. I can't let this information out because I don't have the thing that lets it out. That's true, but it's also supposed to allow the system and with patient consent information to flow. That part gets lost, and it's part of the basics of HIPAA that need to be followed. The other part is HIPAA is not always a good source to tell you what to do. It sort of gives you a big box to work in of what you're permitted to do. So I've operationally, as a tip, I'm trying to get everybody to stop saying HIPAA does or doesn't let me do that. It's almost never HIPAA. It's usually a policy or state law, and then HIPAA is the framework that's built into. Because when people say that, they don't really know what they're talking about, so it's usually not HIPAA. HIPAA just provides a framework to work on. New under HIPAA, an individual can now demand an electronic format of their records. So that was not true before. They could ask, and the hospital or provider could say no, which they did. And now they can't say no. They have to cough up an electronic format. So a couple things with that. That's good. Better flow of information, better, easier to walk it over to your other doctor, take it home, do whatever you want to do with it. We want transparency in healthcare. At the same time, now we got a bunch of disks and flash drives out there that are not encrypted that people are going to lose or get stolen out of their car, and we're going to have another disquieting event when everyone realizes their stuff's all over the place and how much stuff there is. There's some confusion over what the legal record is or your designated health record. If you went into a doctor's office, medical record system, or hospital, there's a lot of metadata there. A lot. So when they cough up whatever it is you're allowed to get now, it's going to look like gobbledygook to the average person. It doesn't look like when you print it. So that's going to be another oddity that comes out of this. There's something in HIPAA called the minimum necessary standard. It basically means that you are on a need-to-know basis, except for treatment. Anything else you do with information, if you're a HIPAA-covered entity, must be on a need-to-know basis only, including for payment or any other operation you do as a healthcare vendor. They have changed this under high-tech so that you actually have to prove why you're doing that, which sounds like a good idea. It probably is a good idea, but it's not what they were doing. So we're going 0 to 60 on we do stuff because we know we need it, and now they have to prove every time they use information, other than for treatment, why they're using that set of data, which is a really big paradigm shift for providers. So more guidance is expected. It's written into the rule there will be more guidance. They have 18 months to do it at HHS, and they are struggling to get there in the 18 months because this is a very tricky thing on how to explain to a provider it's not its information. It's information that it can only use when it's allowed to. There's something called the accounting rule in HIPAA, which they have changed in high-tech. The accounting rule in HIPAA under the Clinton administration draft was to allow a consumer patient to track where their information had been, except within a provider. So where it went, did it go to DCF? Did it go to the police? Did it go to an insurance company? That sort of thing. And by the time the Bush folks were done with it, this is just true, I don't mean to be political about it, it was so stripped down, it swallowed itself with exceptions. They've put them back in. So this is going to be relative to when electronic health records are adopted, which is 2014 at the latest, under all the new ARA rules, that you are required to tell each patient after they request it where their record's been anywhere it went. And that's also going to be a disquieting event because it goes a lot of places, most people don't realize, outside of the organization. So that's a huge change that must be not only accepted mentally, but filtered into all of the EHR systems, which are not set up to do that right now. And they have till 2011 to do that. Something called a limited data set, which is basically a research term for using zip code and dates. And they have changed the use of limited data set to be the thing that is the minimum necessary standard, which doesn't work for anything but research. So it's sort of this looks like a misstep on the folks who wrote this part of the rule, and there'll be more guidance on the limited data set and why it is. Here's a biggie that doesn't get talked about enough. In the high-tech, there is a prohibition on the sale of protected health information or electronic protected health information. You would have thought there was already, but there really wasn't. And what they're focused on is stopping providers directly, sometimes indirectly, from selling information to drug companies. It doesn't say that, but it might as well just say that. They're trying every way to block that because it still happens. And the exceptions are limited, and they're in front of you. So they're not supposed to upset the status quo of regular information that is needed to be moved from place to place. But the point is, anytime money changes hands for data, whether it's for research or something else, it has to strictly fall under the rule and the guidance that's going to come out. That's a big change. Because right now, a lot of information goes around that folks don't know about, and this is going to be a very different way for providers to look at it. They changed something called the fundraising rule. You know, if you ever go to a hospital or any not-for-profit provider, you then get mail from them for the rest of your life asking for money, which is how they do fundraising. The fundraising rule has changed that if you ever opt out, please stop sending me this. There's supposed to be a checkbox for that. There really has to be the checkbox, and they really can't send you anything ever again. What happens now is you go back because you have a different encounter at the hospital and they start sending it again. They can't do that. Apparently this upset people enough to put it in the rule. Here's a tricky thing that is going to be, no one knows how to implement this, and it goes into effect February 18th. You are now permitted as a consumer to say to the provider, wait, don't send this to my MCO, HMO. I don't want them to know about today's visit. I'll give you the $260, and you never show them this episode. In the paper world, that's almost possible, if you could get enough people to think it through and put red tags on it. In an electronic world, it's almost impossible. So you go to a doctor, you go 7 visits in 2 years, and you've just, number 5, you don't want your insurance company to know. You're allowed to stop them from knowing that. And the physician has to figure out how not to send that information. This is going to be tricky. And a good idea because people should control their information, and a bad idea because it's almost impossible to do, and it's going to cause a lot of you told me this, you didn't tell me that kind of stuff. But that's a real rule in high tech that updates HIPAA. Change the marketing rule, again, to stop drug companies from buying information. It just drives them crazy. So they have tried to tighten it. They thought they had done it before. And what happens in what's called the marketing rule is any time a covered entity, usually a provider who bills electronically, could be a health plan, is paid for marketing, to market to you or to give you information, it can only be for a drug you're already on, which really cuts down on the marketing because you're already on it, or if you have the authorization from the patient. That's a huge shift. Believe it or not, they used to be able to before they could market to you. They don't necessarily send it out to the drug company, but they give you samples or things that are tied to a coupon. You can still give samples, but they cannot encourage you to use a different product. That's a change. It was a pretty big change. Other things that are in the high-tech rule for HIPAA, they have about, I think we counted 14 more sets of regulations that have to come out for this over the next 18 months, and it's a lot. So that's going to keep coming out, and they have to do a whole education series to educate the public and covered entities on what they're supposed to be doing because they don't really know. There's also enhanced enforcement. Again, talked about there's this lack of enforcement. It created sort of a slide, totally true. We also created a lot of urban myths in the meantime of what you can and can't do because no one enforced it, so people guessed and they thought they were right because nobody caught them, sort of like embezzlers, but they weren't. Individual employees have criminal culpability. That's a serious thing. They've tripled and in some cases quadrupled the civil money penalties for HIPAA. State attorneys general have the enforcement power of HIPAA. They never have before. We've been arguing for years they shouldn't because we don't want 2 different answers, and now we're going to get it. 2 different answers. And the Office of Civil Rights, who always oversaw privacy, will now also oversee security, which is, it sounds small, but a huge thing. At least we're going to get the 2 big rules on the same page, because we used to get 2 different answers all the time. CMS was doing security, and they're not going to do it anymore. And these are just for your own fun. And do they have access to the handouts? Yes. Great. Not to go through these. These are actual HIPAA violations that you can flip through. They're available online, which makes them pretty good reading of what people do, and you think, how could they do that? And some of them you think, uh-oh, I do that. So it's an interesting grouping, but they're not for discussion. And I'm done.
Thank you. Thank you, Jennifer. That was a lot of great information, and I never knew HIPAA could be so funny. So I'm Elizabeth Laird with the Data Quality Campaign, and I'm going to talk to you about the F word, which is FERPA. But before I do that, I wanted to start with the title of my presentation, which is actually pretty strategic, which is that we both need to protect privacy, but also ensure that the data are used, that it can't be one at the expense of the other, and really the campaign is very committed to finding a way to both protecting individual privacy, but also really leveraging the power. We have this great wealth of information. How do we really use it to make better decisions? So along those lines, before we talk about confidentiality, we always talk with why are we even doing this? And the campaign is really committed to improving data for education data longitudinal data that follow children from early childhood through post-secondary in the workforce, but then also horizontally, which is what we talked a lot about today, of how do you then share data horizontally with other agencies. And we believe that if you do that, you can help teachers, parents, and students have the information that they need to really individualize instruction. You can administrators can do a better job managing the system. And finally, policymakers can really use that information to make better, hopefully, policies. So the Data Quality Campaign was founded in 2005. It's a national collaborative comprised of these managing partners. And if you just look through the list of partners, it's really no small miracle that we could come together and agree about anything. And the fact that it happens to be better data really speaks to the power that regardless of where you sit, that having these diverse list of organizations come together and agree that we all need better data to inform our work is really the power behind the campaign. So what you see there is, or maybe don't see, which is a good thing and a bad thing, these are all of the opportunities in the stimulus funding that's available for education data systems. And so it spans 3 agencies. You've got the U.S. Department of Education, Health and Human Services, and the Department of Labor. So the good news is there's a lot of funding to actually do this. We've got the momentum behind it, and for the first time, the resources to do it. The bad news is that a lot of these times, and we talked about it today, these efforts aren't coordinated. So you've got these monies going to different agencies, and the left arm doesn't know what the right arm is doing. And so how do we really make sure that all of these funds are leveraged in a way that we're all moving towards the same goal, which is ultimately improving outcomes? And one of the grants that I'll actually point out is the first one, and there's some written about it in the primer, but it's the statewide longitudinal data systems grants, which is administered by the U.S. Department of Education through their Institute for Education Sciences. And this in education has been a tremendous catalyst to really improving the progress of state data systems. So that, through the No Child Left Behind Act and the accountability requirements that were part of it, states really began to develop their systems, but once the federal government really got behind it and started to put funding into it, the states really took off. And I'll just point out the figure, which is that when it started, it was $15 million, and now it's $250 million, which we think is a lot of money, but when you compare it to the money that's going to go into electronic health records, it sort of pales. But it is to say that you've got this education train that's really going and picking up momentum and picking up steam. And then you've also got a lot of effort going behind these electronic health records. So how do we really make sure that they don't collide? And when they do, it's a happy collision, and one in which the two leverage each other, and not one in which we really should have thought about doing this when we were developing our electronic health records, or we really should have built in the capability for state education data systems to accept health information. So as part of the campaign, what we've done is we've tracked the progress of state data systems by administering an annual survey that state education agencies respond to with respect to where their state longitudinal data system is. And so you can see on the left, the map is when the campaign was founded in 2005. How we've defined a longitudinal data system, which I'm not going to get into today, but you can read more about, is we put forth 10 essential elements of a longitudinal data system. The first one being a unique statewide student identifier. That's really the foundation. If you want to be able to connect records and follow children over time, they need to have that unique identifier. So as you can see in 2005, when the campaign was founded, no state had all of these 10 elements. And when the campaign released our recent survey results in 2009, now we have 11 states that have all 10 elements of a longitudinal data system, which speaks to the power of both the momentum and that's happening at the state level, and then also the importance of fueling that at the federal level, but also that if you put something forward that's manageable, having 10 elements, and making the connection between this is what data will actually do to make people's lives better, and make that case to policymakers that they will actually start to move forward and make progress. With that said, one of the things that we learned is that just because you built a really great data system, it's comprehensive, it has a lot of information in it, doesn't mean anyone actually uses it. And so that's a problem, right? So it's not what we talk about. It's not about building a data system for IT's sake, and it's not something that should be kept in the basement where data manager get down there. It's really come up. We're having these discussions. How do we really make sure that what you're doing informs our work? And that it came up earlier today of how do we make sure that the business drives the IT and not the IT driving the business. And so that's really where we're focused at now, is really how do we change the culture around data use, which has come up over and over again of the technology. That's the easy part. I mean, it's not easy by any means, but it's certainly easier than changing the way that people do business. And so that's where we are now as a campaign. It's really trying to change the way that people do business. And so to that end, we've identified 3 sort of buckets of information or actions that states should take. I'm not going to go through each of them. I'll just point out one of them, though, which is the ability to expand these education data systems that are being developed to link with other systems, both north-south or vertically, so from early childhood through post-secondary in the workforce, but then also east-west with social services, with health, with criminal justice. So how do we make sure that, again, we're breaking down these silos and not resurrecting more? But the one that I am going to spend a little bit more time talking about, which is germane to today's discussion, is how do we ensure that these data are accessed, analyzed, and used? So that just because, again, we have state education agencies really have, for a while, been sitting on a pretty tremendous wealth of information, but the phrase is often used, we're data rich but information poor, because we have all these data, but they're really used for compliance and accountability purposes, whereas we want to change the conversation from using data for accountability purposes, which has its place, but how do we really use it for continuous improvement and really improving the way that we deliver services and the way that teachers instruct and the way that parents make decisions about what schools their children attend, and policymakers, how do they really put funding behind policies that we know work? And so as part of that, we have to ensure that data, again, are accessed. And so we have, just like we have, the 10 is the magic number, that's the punchline. So we have 10 elements, we have 10 actions. One of our actions that is really germane to today's panel about confidentiality is implementing systems to provide all stakeholders with timely access to the information they need while protecting student privacy. And so again, yes, there is this tension, but we have to find a way that both of these can coexist in a way that we can provide access, but we can also protect student privacy. So the F word. This is, so when the campaign launched, it became immediately apparent that both real and perceived barriers around FERPA, the Family Educational Rights and Privacy Act, really were impeding states' ability to both collect information, but certainly to give people access to it and to use it to make better decisions. So we've really, since the beginning of the campaign, have been calling for clarification of FERPA to really make it clear about what you can and can't do with these systems, because we don't even have that much. 22 years before HIPAA was enacted, FERPA was created. I mean, if you think about where technology was in 1996, think about it where it was in 1974. And so there's still, and to this day, there really haven't been any significant revisions to it. And so what we want to do is really clarify FERPA. And it puts forth some thinking about what needs to be clarified to really leverage technology. So again, as Jennifer said, it's about protecting the privacy of education records. It applies to personally identifiable information. It does not apply to information that is not identifiable. It applies to schools and local education agencies or school districts that receive funding from the U.S. Department of Education. An important case that really sort of influences the conversation around FERPA is the Gonzaga University versus Doe case, in which the Supreme Court ruled that an individual could not sue for violation of his or her individual rights. In other words, and I'll talk about this later, but an individual and a parent cannot sue a district or a school or a state agency for a violation of this, which is different than I think Jennifer described in HIPAA. And so at the end of 2008, the department released some clarifications that I'll talk about later. Some went, it did do some good, but then there are certainly issues that are outstanding that we really believe need further clarification. So again, if information is not personally identifiable, sharing is permitted. If it is personally identifiable, there are circumstances in which you can disclose information to outside agencies without parental consent. One is to evaluate state and local programs around school and district accountability. You can monitor and analyze assessment, enrollment, and graduation data to improve instruction for individual students, which if you're going to help individual students, ergo, it must be identifiable information. Perform studies to improve instruction. You can partner with outside agencies to conduct research on your behalf, considering provided that you put forth the right guidance and the right agreements. There is that ability to do that. And then the sharing the student records among schools. So if a student transfers from one district to another, the receiving district can, the district that the student is leaving can send that student's record to the receiving district without parental consent, as long as the parent is notified that that will happen in the event of a transfer. And then lastly, maintaining a teacher identification system that links with teachers and students. FERPA doesn't apply to teachers. There's no reason to think that it does, and so there's some flexibility there too. So 7 FERPA myths, and I have to say this is not based on my own thinking. This is, we work with a great attorney, Steve Winnick with Education Council, who's done a lot of analysis for us in terms of what FERPA, how it can really, the flexibility that states can have in terms of using data systems to improve student achievement, but then also areas that need clarification. So the first myth is that federal privacy laws are aligned and consistent. I think Jennifer alluded to this in her remarks, but there really is a lot of ambiguity around FERPA, and some of the other federal privacy legislation like HIPAA actually is more clear about what you can and can't do with data. And so how do we make sure that these federal privacy initiatives are not just a rule that you don't want to think about too hard because it doesn't make sense, to how do we actually make sure that these are aligned? States and districts are in jeopardy of court action and monetary damages if they make unauthorized disclosures under FERPA. This goes back to the court case that I mentioned, which is that individuals cannot sue. The only penalty or ramification that can happen if there is a violation of FERPA is that they're at risk of using their funds from the U.S. Department of Education. With that said, they're also given an opportunity to correct the violation, and so to date, no school district or state has actually lost any funding as a result of FERPA. The third myth is that the congressional intent in enacting FERPA was solely to protect the privacy of students, and while that was certainly a major thrust behind it, those exceptions that I mentioned of when you can disclose data, it's also really about talking about what you can do with data and making sure that it's not just about protecting confidentiality, but you can do that, but also support really good uses of data, like improving instruction, like good research, to make sure that we're improving the system as a whole. So permitting states to redisclose records for purposes authorized in FERPA is a serious threat to student privacy. This is one that really the states are dealing with the same players as the district, and so there's cause to think that it's really the states that's acting on behalf on the district, and so it's not a redisclosure. They're actually working in tandem. A state post-secondary data system may disclose education records to a separate state P-12 data system only if the P-12 system has legal authority to evaluate the post-secondary education programs. What does that mean? It means that right now what we have data that go up the pipeline. They go from early childhood to K-12 to post-secondary, but they never get that data back, so they have no idea how the graduates of their programs do. So what this is saying is that you actually can provide that data back to the local system or to the K-12 system so that they can do a better job based on knowing how their students did once they graduated. The sixth is that it prohibits the authorizing disclosures for studies for and on behalf of schools and districts. That doesn't apply to state-level data. This goes back to the idea that if states are acting on behalf of the district, that they also have the authority to commission studies on the district's behalf. And this one is I think, especially relevant today, which is that no workforce agency may use education records to evaluate education programs because the state education agency does not control the workforce agency. And this also applies to social service agencies, but we think that there really are some ways to do that with really good interagency agreements. And so it's hard work to really put in place these interagency agreements and come to a place of trust where you hand your data over to someone, but there really are ways to do it, and there are states that have begun to do so. So with the December 2008 revised guidance that came out from the U.S. Department of Education, again, it clarified some things, but these are the things that we think need further clarification, which is sharing the data between P-12 and post-secondary data systems, making sure that data not just go up, but that they can come back, that we need some actual guidance from the Department of Education saying that this is okay. Disclosing education records for research studies, again, when can a state enter an agreement on behalf of the district to conduct research and when can't they? And then the third is to disclose to a former school LEA for evaluation and accountability. So instead of just having the record go from one school district to the receiving school district, actually allowing the receiving school district to send data back to the district that the student came from. And then the last one is the authority to share education records with workforce and social service agencies. And of these four, unfortunately, we think that this fourth one is the only one that can't be clarified with revised guidance, that you actually need to amend FERPA to clarify that you can share education records with workforce and social service agencies. So what do? We review and clarify state law and regulations. So FERPA, seeing how FERPA really relates to state legislation with respect to privacy, states have the authority to pass their own legislation that's more restrictive than FERPA. So how do we go back to that and make sure we review and clarify it so that if there are things that need to be changed to enable the data to flow from post-secondary back to K-12, that we take care of that in state legislation. Creating a data governance structure. One of the key things that we found in places that have really been able to make this interagency data sharing work is that they have a structure in which these conversations happen so that it's very clear about what the data will be used and what they won't be used for, and there's a forum in which you can have these conversations and really start to build that culture of trust. Create interagency data sharing agreements, put in place what you want to do with the data, what questions you're trying to answer, and who has the authority and the responsibility and the accountability for what comes out. And then also educating the parents and the public about why would we even want to do this? So how do we create that demand for records to be able to flow across traditional boundaries so that it does trickle up to policymaker level and we do really change how we are able to share information, because without that, it's still sort of this IT project. And then last is issue guidelines for authorizing studies initiated by third parties, which is again being able to have outside entities and organizations look at your data, analyze it in a way that you don't have the capacity for at the state education agency. Thank you.
Good afternoon, everyone. My name is Don Will. Thanks for having me here today. I'm from the California Administrative Office of the Courts, where I should clarify, despite the agenda, I'm not the senior director, unless something happened while I was on vacation. It would be surprising. I'm a manager at a division called the Center for Families, Children, and the Courts. We work very closely with all of the juvenile and family courts in California. We also work closely with all of the child welfare departments. So we're kind of deeply embedded in the juvenile dependency and delinquency systems. And I have really, Jennifer and Elizabeth did a wonderful job of kind of intimating that HIPAA and FERPA are complicated topics. I have not a lot to add to that, except to say that one last thing, they weren't written with children in the foster care system in mind. And so I think maybe that's the only thing I could add to that wonderful overview, is that there are lots of children who don't have a parent who can make information sharing decisions. They have a judge, they have a social worker, they have relative guardians, foster parents, a whole great complicated web of relationships that makes it even harder to share data. What I'm going to talk about is how do you go from this place with these very complicated laws into helping local jurisdictions and state jurisdictions share the information. There are plenty of them doing it. There are plenty of them not, because they don't know how to go about it given this regulatory framework. And there's some who are sharing, but ask us, please don't tell anybody, because they might make us stop. And it's really working for us and helping us. So we are working from there and being sensitive to that. I'll start with a statewide multidisciplinary commission in California, the Blue Ribbon Commission on Children in Foster Care, whose director, Chris Wu, is here today. The Blue Ribbon Commission, along with many other national and state bodies, has recommended that we try to deal with information exchange and information sharing so that the judges and the social workers and the foster parents and the teachers and the doctors can all do their jobs. After the Blue Ribbon Commission was well along, another commission started up in California, the Child Welfare Council. That is also a multidisciplinary commission that is here to make child welfare improvements. It has a committee on data, and we're lucky to have Dr. Barbara Needell, who's a council member and sits on that committee. And that committee is looking at information exchange and trying again to figure out how to make it happen and how to protect everyone within this legal framework. There's no simple statewide solution to this. I think maybe there can be a statewide strategy. There's a lot of data sharing going on. There's a lot coming down the line as big jurisdictions like the California courts, the child welfare agencies, child support mount new data systems which will be able to exchange data. However, all of these are at the mercy of differing interpretations of confidentiality law, and they can be stopped by any number of people at any time. Often we find the key player in this area, which is not the technology and it's not the kind of functional data, what data you share, but the legal area. The people we work with the most closely are the juvenile judges and the counsel for county departments. That would be for departments of social services, and then counsel for boards of education, and sometimes for medical providers. They don't have good guidance on sharing and exchanging information. Obviously, if we could clone Jennifer in California, so there were a Jennifer in each of the 58 counties, it's what we need, but we don't have that. So how do we bring it together and use our statewide commission to make some changes? Go ahead a little bit. And just to further complicate it, just to say a couple of things about the child welfare system in California. It's warmer there. That's one thing I've noticed so far. It's a county-based social service system, and so each county has its own independent agency. The State Department of Social Services has a lot of funding and oversight authority, but you can't say something and have it happen in all 58 counties. The courts are actually state-based in California, but they have a long tradition of local decision-making. So again, we don't set something by fiat in San Francisco or Sacramento and have it happen in all of the courts. It just doesn't happen. Each county, each superior court tends to look at problems on their own and make their own decisions. We also have county-based probation departments, and we have local boards of education. So what is our strategy for facilitating information exchange in this system where you have many people, many county council who can stop a proposed exchange of information? We thought a while ago now, when we were working with the Blue Ribbon Commission, that a good place to start would be to put everyone into a room, all the county council, and say, okay, figure out how to exchange data. But after quite a bit of work in the Child Welfare Council and our own research, we realized it's just too complicated to do that. The first question would be, well, to exchange what data and how and for what reason, and it would take a whole lot longer than a day. So as we work on our strategy to make this happen, what we did was we at the AOC, the Administrative Office of the Court, sat down and wrote 4 briefings on confidentiality law, which I'm happy to share with you. They're in draft, but I'd love to hear anyone's comments. So there's one on HIPAA, there's one on FERPA, there's one on mental health, and there's one on substance abuse. And really the ones on HIPAA and FERPA are on health care information and education information, because there are many, many, many more laws, regulations, rules, and case law that feed into those. We kept the briefs at the level of a very, it's not planned for an attorney, it's planned for a kind of general policy maker. And all of the briefs are written, they're all 4 to 6 pages, they're written with the kind of goal in mind of saying, here's what you can share, and then here's where it's unclear. So to kind of bring forward in a positive light all of the information that can be shared now. But we also wrote the briefs just to get the discussion started. We expect lots of people to disagree with what's in the briefs. We expect lots of comment, and we expect them to spark discussions, which is good. We're not wedded to what's in the briefs. What we're interested in is in this network of council to county departments, juvenile judges, other stakeholders. We're interested in surfacing their problems and trying to find solutions to their legal problems. So we're circulating the summaries. Then we're going to hold focus groups with county council around the state. And at those focus groups, they'll have read the briefs ahead of time, and then we're going to present scenarios for information sharing and work through them and try to surface what the key problems are, what a county council would need in the law and the regulation, what have you, to sign off on this scenario for information exchange. Then we're going to work out solutions. What do they need? And that goes back to something that Elizabeth said, which is you do need some kind of structure for data governance, some way for people to come back together and say, what can we do? And we have that in the Child Welfare Council, both in the data committee and the council as a whole. It's not an official governance body, but it's a body that includes high-level decision makers, legislators, all kinds of people who can take legislative fixes to the state, who can do policy guidance to the state and local agencies, and who can go to the federal government and ask for guidance. Though I would say sometimes that's a mixed bag. So we bring, I mean, you have to be ready to ask. We take this back to the Child Welfare Council and the Blue Ribbon Commission, and we go from there. We're expecting to have that done by June 2010. We're hoping to have a meeting about putting forward our agenda for change at what we call the Beyond the Bench Conference, which is a big multidisciplinary juvenile dependency and foster care conference in California. That's in June. So I'll leave you also with a couple of lessons that we learned as we went about this process. At the beginning, we tried to keep our focus on electronic records exchange, the way I think a lot of us at this meeting are focused on. That's very hard to do given the way that the law is written, given the day-to-day problems that people work with, and what we have really needed to do is go back and root our discussion in basic kind of case management, because the law is written about sharing pieces of paper with one another, and that's where we have to start. We identified 3 kinds of information exchange, that kind, electronic information exchange, and the exchange of data for research, outcomes, performance measurement. Some of those are easier, some of those are harder, but we keep it at the level of the way the law is written. I already said that you can't order everyone into a room and say, fix it. We're going to need a wide range of fixes: education, legal fixes, regulation, policy guidance. The final piece I'll leave you with is that I think youth and parents are an important stakeholder group in this. We found that out through the comment process with our first report to the Child Welfare Council. And as soon as it happened, I think it struck many of us as, of course, you shouldn't sit talking about policy for information sharing without involving the youth and the parents whose information is going to be shared by these systems. So we're also working on that. I hope I'll include the drafts for these briefs in your materials. I hope that you'll all, if you're interested in reading one of my hard copies, I brought a few, And I hope anyone interested will read them and give us comments on them. That's me. Thanks.
All right, do we have questions then we have a couple minutes for questions for our first three panelists. Yes?
Yes, perhaps either of the first two presenters. Could you provide a little more color on information sharing related to PII and what are good guidelines to follow when the personally identifiable information is not provided, but or when it can and can't be shared across different services organizations?
It depends. Which is apropos to what Don was just saying. From a HIPAA perspective, so it's assuming HIPAA's in it. You're either a HIPAA covered entity or you're sharing with a HIPAA covered entity, and that's where it gets gummed up. The purpose of why it's being shared is what regulates whether it can be shared or not. So if it's required by law, or it's a public health authority, or it's research with certain things, then you can. And there's another 18 things I could tell you that you could or couldn't. So the part of the problem with HIPAA is it's just so darn complicated. So it's so prescribed in what the sharing of information can be. It actually is a case-by-case determination.
And Jennifer, can you tell people what TII, is that what you said? Okay, could you explain that? Because it certainly went over my head, clearly.
Personally identifiable information, yeah.
Okay.
The interesting thing about all these different rules, and we only mentioned about 5 of them, there's actually probably a dozen that are just as confusing, is they use similar terms that are not similar but not the same term, and then they define them differently even when they use the same words, which is awful. HIPAA has several of these. It has protected health information. Okay. Which is actually information of a covered entity or a business associate, the types that I told you about, and their vendors, that is about their health care and or demographic information that would identify them. So that's protected health information, which is a covered entity. Then there's personally identifying information, which is somewhat of a common term across the things, but not exactly the same, which is basically demographic information that would identify a person, which goes right down to your driver's license number, your driver's plate number, your employer's, your zip code. It's pretty broad on what personal identifying information is. When you aggregate it, even in HIPAA, you're often able to disclose it if the re-aggregation or the de-identification couldn't be tracked back to the individual. So aggregated data can be shared much more easily in HIPAA than it can be in other systems, not substance abuse issues, and probably not in FERPA as easily either.
Okay.
They fixed that when FERPA was having trouble with aggregated information sharing. HIPAA allows that.
Yeah, no. So if it's not identifiable, then it's not an issue under FERPA. So with respect to exchanging like education and social services can send data to education. They can match it, but they can't send back identifiable information. So, but they can send back aggregated information. So it helps with research and sort of policy discussions, but it does not help with service delivery.
Okay. Other questions? Yeah, right here.
Easier to share between? It's not.
No, I mean, and where the government is now is they are having discussions about issuing updated regulations, which we think will address the first 3, but not the last one. And so we expect that when it comes out, that the next step is you're going to have to amend FERPA to say that these agencies can share data for purposes other than improving instruction, which is what it says. So you can't share data to improve services other than sort of educational services.
Great. We have time for one more question over here.
Yeah, within FERPA, I believe there's a notion of directory information, which basically is some things they use for normal public consumption that they release. Is that an avenue we should probably look at as being a first step to try and get some flow of information? Because what we're looking for is the basic demographic, not necessarily school-related information about grades, attendance, et cetera.
Sure. I mean, yeah, sure.
And is it easier? I mean, would that be an easier case for the lawyers to grapple with?
I think that's exactly what we're running into, is what Don described. It's the culmination of, it doesn't matter if it's HIPAA or FERPA, you get enough lawyers in a room and they will ice it because they're afraid. They do not want to be the lawyer that causes the $5 million fine. They just don't. It's so much easier to say no for a lawyer than to find a solution, which is a problem. So in HIPAA, FERPA, there's a lot of aggregated type of information or high-level information that can be used, but what happens is they get in the mindset of if I have to use individual information, it might be tracked back. You know, if these 10,000 things happen, folks won't let it go.
Well, hello, everyone. All things happen for a reason. So as the other panelists were talking, there was a homeless shelter in my county that was being flooded and collapsing, and I was like, please let my turn not come. Please let my turn not come. And so it did happen that way. So I just want to tell you, it's wonderful. The crisis is now resolved, and everyone's situated for the night, so I can actually do this without worrying about which BlackBerry message am I missing. So that's real life, right? I'm glad I get to talk to you about how we can breach the barriers of confidentiality. So we're not going to talk from a lawyer's perspective. We're going to talk about all the risks that public administrators want to take to share information. So I told Jennifer she has to close her ears for this part of the conversation. Every time I stand in front of an audience and talk about confidentiality, the county attorneys just go crazy. And they have told me that I cannot speak to what we're doing in the county because if the feds, none of whom are in this room, hear about what we're doing, they would immediately let the Department of Justice know, and we'd probably shut down. No, we're doing everything very legally, I should tell you up front. Now, none of this stuff is being done outside of the pale of law. So, does that work? Yeah. So, in 1996, in the throes of a 1990s budget crisis, some very forward-thinking person, the former county executive and the former director, decided to merge 4 departments under one roof. And they merged public health, addictions, victim and mental health services, aging and disabilities, and family services into one department called Department of Health and Human Services. We have Carol Pearson's here from Walter McDonald. She remembers those days, and we were just chatting a few minutes ago. Public health has a culture that is completely different from social services, and then there's behavioral health and homeless services and all of everything else that makes up our world. I come in 3 years ago into a world where the first thing the executive says to me is, Emma, why are you integrated? All we've done is create this mega bureaucracy, and it doesn't appear that the value of integration has been fully realized. So I actually took that as a mandate. I don't know if he meant it as a mandate, but I did take it as a mandate. And for the past 3 years, we've been working on service integration and interoperability, and into this world walks and stewards of change, and life takes off, actually. So the purpose for us is to have an integrated, coordinated, and comprehensive service delivery system. So towards this end, well, there is one director, which is wonderful for governance. People keep referring to governance. There's one department director in all these service areas that deliver literally birth-to-death services. We're moving towards one client database. We have developed a universal intake form. We have developed the 13 data indicators that we believe need to be universal across all of our programs. So we've developed our face sheet, we've developed our universal screening tool, we've designated our entire health and human services entity as a HIPAA-covered entity, including our social service and income support programs. And you wonder why we did that. Actually, part of what we wanted to do was, the rationale for that was that in 2003, by the time HIPAA rules came out, DHHS has already made significant progress towards integrating. So when we say DHHS, we mean county government, so not to confuse with the federal partners, who are also in Rockville. We love to have them there. So if people confuse us, it's not a bad thing. No, not true. But all DHHS client identifying information is confidential regardless of the service, because different statutes apply to different programs. And there are so many numerous privacy laws that impact us. So treating DHHS as one entity actually created consistency across our platform, which was something we thought was very useful to do. So that is the context. The rationale, then we said we'd already made progress, there was consistency. Legal requirements, state laws, we actually amended the state law to treat Montgomery County like one entity for purposes of confidentiality. We're not like the rest of the state. All the other counties in the state are state-administered, state-supervised for the most part. They have a Department of Social Services, Department of Health. Mental health is at the county level, so through a core service agency. So things look different in the rest of Maryland than it does in Montgomery County. And then wherever there are more stringent federal laws, then we like 42 CFR Part 2, as you heard, we defer to that. HIPAA compliance, sharing of information is permissible based on purpose. This is what you hear over and over again. And for treatment purposes, sharing is permissible both within and outside your entity without client authorization. And so that's the hook that we've been using to drive our interoperability and sharing of an integrated case practice conversation. Let's see, just make sure. So treatment became the defining piece. We had to define treatment before we could move forward. One of the things I realized early when I came there was that there were two things missing in the department around integration. One was a clearly articulated practice vision as to why integration is important and why would everybody, clients coming in the door and staff, recognize why this was important. And so we needed to work on a practice framework. And the second piece was that confidentiality is often used as an excuse. Well, we can't do it because HIPAA won't allow us. And it isn't all an excuse. I mean, the department's made up of mental health therapists, social workers, nurses. The academic institutions, our social work programs, our nursing programs teach us to protect privacy. They're not necessarily saying it's important to interoperate. And so there is a framework for even our schools, to academic institutions, to think about how do they want to teach practice in a different context. So treatment's interpreted pretty broadly. When a client has multiple service needs, and one of the things I'll tell you, last year we served about 70,000 unduplicated households. Over 39 of those households were using more than 2 services from the department. So that speaks to why it's so important for us to share information for purposes of treatment. But then we decided to define treatment a little broadly. HIPAA privacy rules define treatment as the provision, coordination, or management of healthcare and related services. Related services for us includes social services and income support programs. There is actually I should tell you, there's actually an interpretation, one of the rulemaking advisories that DHHS put out, that HHS put out some time ago, that says addressing a client's basic food or shelter needs greatly impacts the effectiveness of healthcare. And so that's the category under which we open the door for social services to be included in the sharing of information across our system. And until we found that hook, I could not move the county attorney. It took about 18, 19 months for us to frame our confidentiality policy. And it was because we had a fabulous county attorney who was sitting with me, and he said, Uma, we're going to get you there. We're going to get you there. It doesn't matter how long it takes. And they kept searching, and he directed his staff to say, okay, I know how risk-averse you are, but we're going to try to make this happen because this makes good sense. So both the intent of the law and the language in the rulemaking process, we believe, supports this broader interpretation. Now, DHH's clients are largely low income, so addressing the holistic needs, food, shelter needs of clients have a great impact on effectiveness of health and mental health care. So I often like to use the case of a homeless diabetic woman who's had 3 episodes of hospitalization, and the healthcare side is trying to stabilize her diabetes, maybe the homeless side, or maybe she's not connected to the homeless system, but she's trying to find a place to live. Well, unless she has a refrigerator and a stove in her house, she has a medicine cabinet, you're not going to stabilize her diabetes. And she has a medical home because she knows where she's living, and she can get to her primary care physician every time. It's not going to work. So the siloed approach to treatment or intervention just doesn't cut it. And because we've got that whole client view, we are really committed to trying to pull those threads of information and try to integrate. HIPAA was not intended to create barriers to care, but rather to prevent misuse of information. So we like to keep repeating that for our staff. And actually, once we have the legal blessing, you'd think, okay, we've got a policy now, everything's cool. It isn't. There's a lot more work to be done to get practice to actually change at the front lines. And during rulemaking process, this is the piece. A federal DHHS response to a comment clarifies that related services actually includes social, rehabilitative, and other services that are associated with healthcare. Information may be shared between programs for all of the following treatment purposes, so determining eligibility, making referrals, case managing, and coordinating services and establishing a service integration team. These are the purposes for which we've defined our confidentiality and privacy policies, and we're training our staff to. So what is it? But the clients actually have a right to be notified of their privacy practices, and they have a right to request a restriction on how their information is shared for purposes of treatment, payment, or healthcare operations. And so what we've created is an opt-out policy, not an opt-in policy. So by that definition, what we say to clients when they come in is we give them our policy, which is actually in a one-page format for them for ease of use, though it's actually a 12, 14-page document for the rest of us, right? But it says in there, we consider ourselves one department, and if you receive services, then we want you to know that for purposes of treatment, we're going to share your information across this entity, except 42 CFR and domestic violence statutes, which are more restrictive. So those exceptions still exist. We'd love for those statutes to be modified, but there's no way around them. But we share for this purpose. If you don't want us to share it, then you have to ask for a form to sign yourself out of. That would prohibit us from sharing our information across the system. And so that opt-out, we believe, given that that will bring in about 90% of our clients, 95% of our clients into the fold for us to be able to share information. And we do have protocols in place. If someone says, don't share my information, doesn't mean they don't get services, they just don't have an integrated approach to service delivery. That's the difference. So, and we do have criteria set forth in policy for evaluating such requests. Now, compliance with other more stringent federal laws, to the extent that other federal policies require additional protections, such as, 42 CFR Part 2, which we have to obtain a written client authorization to share information even within our other DHHS programs. So that one's not in the fold. Programs covered by FERPA, as you heard earlier, it doesn't really permit a lot. But one of the things we're finding, we're doing a project with our school system in a school district. We have done a carve-out between a high school, a couple of middle schools, and elementary schools. And because the parents are sitting at the table as we case plan in a multidisciplinary way, the parents are just signing permission. And our attorneys and the school system's attorneys work together. There's always only a one-way sharing of information on student-specific data, but we recognize that and we just keep going forward. And we've actually developed some cool protocols that I think will help replicability across the school system that will enable Health and Human Services and our public school system to work together. Programs focus particularly on domestic violence, sexual assault, or victim services. Those are state statutes are very, very restrictive. And long-term care ombudsman program for nursing home information. So barring those 4 programs, we have over 80 programs in the department. Barring those 4 clusters or programs, we're able to share information based on our confidentiality policy with we believe with the right protections in place. So the infrastructure, we've created some infrastructure to promote the service integration and at the same time to ensure privacy compliance. We have a revised notice of privacy practices. We've developed that. It addresses all client information, not just protected health information. It addresses, it explains how client information will be used and disclosed for purposes of treatment, both within our multiple service agency, and at some point we want to take it to our partners. So a little bit more than a third, 40% of my budget is outside contractors. Nonprofit partners. So we want to be able to bring them into the fold as part of our team, the treatment team. They are part of our treatment team. We want to be able to share information and make it work. No written consent is necessary under HIPAA if sharing is for the purpose of treatment. We keep repeating that. And that the notice actually lists the more stringent exceptions, such as 42 CFR and the others that we talked about. We have developed a common authorization form, which is a common release form that's across the department. So we don't have 80 different consent forms, which was the environment some time ago. At least each service area had its own consent form, and we've actually worked it down to one consent form. We have a department-wide policy. We have a safeguarding policy that all staff must comply with, a set of practices for handling client information. See how complicated it becomes? I mean, I have a sheet of papers this thick that just speak to all of these issues that all of our staff have to become familiar with. And we're doing more computer-based training and things like that to bring people up to speed. We spend a lot of time talking about role-based access and minimum necessary. What does that really look like? And then this is what we had to get this right to talk about technology and interoperability, because if we don't figure out what role-based access needs to look like, what is minimum and necessary, then whatever we build from a technology standpoint would not meet code, meet requirements, meet regulations. So the goal is to get the right information to the right staff, and only staff with the need to know may have access to information. And sharing, again, is tied to treatment purposes. You can't just need to know because my sister is getting food stamps and I want to know how much money she's making. Well, just because you work in income support doesn't give you the right to look at that information. So we've got to keep training people to that. So we're doing training, more training, and each iteration. And now with these new HIPAA rules around self-disclosure, that's going to lead to a whole new set of training for us. And, we're really trying to figure out what does self-disclosure mean, what happens if it's more than these many people, what happens if it's this kind of a violation, all those things. And then staff with privacy expertise are, we have 2 staff who literally for them, this is their industry. This is what they do for the department and for the county. I mean, they have become the county's source of expertise around both HIPAA and ADAA, because that's also part of their responsibility. So they do both, but they're fantastic. And if they ever retired, we'd be really in deep trouble. They could go make a whole living for themselves outside, more money than working for county government, actually, because they've figured it out. They've helped us figure it out. They're really very good. Respect for client autonomy, critical component of privacy rights and professional ethics. I think here we spend, and unless there are protective factors that preclude it, the client has to be an active participant. Our entire model of service integration is built with the client at the center. So they are part of the planning process, they're part of the information sharing process, because if they don't buy into whatever plan, you hear this over and over again, right? Whether it's child welfare or anything else, if they don't build, if they are not part of, if they don't buy into the plan, then it's sort of self-defeating. They're going to do everything they can to try and sabotage it. Spend a little bit of time, I thought, I'm almost done, to talk about child protection and adult protective services, because these are big protective service programs that local departments have to run. And even within them, it's permitted to share information with other health and human service providers, to conduct investigations to protect the child and the vulnerable adult, and to provide services. And we always tell our CPS or APS investigative staff, there's no need for the rest of the team to know what brought the child into the system or who the perpetrator is or what the allegation was. It is important to build a plan together. If mom needs substance abuse treatment, or if there's domestic violence going on, or if there's homelessness, if these are factors that are going to either prevent reunification or other kind of permanency disposition, then we have an opportunity to sit at the table. And something interesting that's happening now is when we have a family in the homeless system and came in through the homeless door, but their children are at risk. Mom is not complying with what we're asking of them to find permanent supportive housing. There are other things going on, mental health issues, economic issues. We bring child welfare, mental health, other parts to the table to share in the treatment planning with the client. And it's really helping stabilize some of these families and move them even quicker towards permanent housing. It's been phenomenal. And so when one of those cases ever were to cross my desk, my first question is, where's the team? And so people are starting to recognize that those are going to be the questions that get asked. So why not anticipate it and preempt it and pull the team together ahead of time? So DHHS programs are mandated by state law to share certain information with protective services, so other parts of the department. Again, it's a one-way street. For a long time, it's been a one-way street. Reports of suspected abuse or neglect, health and mental health providers must share a limited amount of information to see child protective services. In those instances, client authorization is not required. So clients in CPS and APS, we recognize, do not have the same rights as other clients who are served by the HHS system. It's not voluntary. Their involvement's not voluntary. And so when a child or a vulnerable adult safety is at issue, then the voluntariness of their involvement goes away, and we all recognize that. And so we continue to sort of wrestle with, is there separate policy needed for protective services programming? But we recognize, again, for purposes of treatment, we can still pull them into the fold and have multidisciplinary planning. What is but a family team meeting, but a multi-D effort at trying to address client issues. And whenever possible, we provide CPS and APS clients with the same rights that are provided to clients in other programs. Even though it's involuntary, we try to work through that. So we've had some lessons learned. We've been doing this for a while. It is a process. We have to start small. We have to keep resolving issues and then expanding. So we did not go out to our private providers right away. We started small within the department. If we can't even get our own house in order, what's the point of going out and bringing everybody else in? We're asking a lot of the questions. Sometimes we get good answers, and then we keep asking the questions differently till we get the right answer. And that's something I would say persist with county attorneys or anybody else until you get the answer that you're looking for, because there is a way. It just has to be found. And the easy answer is to say no. And IT is definitely a tool. It's not a solution. And therefore, we have, as program folks, we need to know what we want so that IT can design it around what we want. Confidentiality laws are often misunderstood. You heard that from many different people. We have to train. We have to pour resources into it. And that's the other big challenge. There are no resources. So we keep trying to do this on the side, and we do a half-baked effort. And it would be nice to do it right the whole way the first time. And then, again, no one-size-fits-all solutions for coordination from outside, with outside partners. And so once we open it up and bring the nonprofits in, we're going to struggle with that a little bit, too, trying to figure out what fits where and how. And then we have to continue to recognize achievements. And this has been the fun part of the work that we do, because I make county attorneys so nervous every time I talk about how wonderful the work is that we're doing. So with that, I'll stop. Thank you.
Great. Oh, wonderful. Now, Jerry Friedman was complaining about talking before lunch, and I'm thinking, I'm standing between you and cocktails. So I feel kind of horrible about that. And I also feel like we've been on this race. I mean, it is clearly a Sisyphean task, sort of Sisyphus with a cash flow problem to start addressing, confidentiality and privacy. So what I want to talk about, and slow it down just a little bit, because this has been a lot of information. And I want to harken back to last year when we were at some of you were with us at the Stewards Conference, and others of you were celebrating or lamenting elsewhere because it was the presidential inauguration. And we really turned around and looked at one another in the conference and said, what if? This opens the door, and Vernon Brown is one who reminded me of that, is, what if we could start taking on some of these really big issues? And, is now the time for us to do it? So I want to talk a little bit about privacy rights from a consumer perspective, and also get us moving towards a discussion we're all going to have before we leave and have cocktails tonight about whether or not a nationally cohesive privacy policy is possible. Oh, nothing's happening, Daniel. There we go. Okay. So, I love this topic. I mean, it is so complex, and I just want to recap really quickly some of the things that I heard from the presenters today. Jennifer mentioned, oh, wow, what if we had a cogent way of approaching privacy? And Elizabeth talked about, aligning privacy protections, that being one of the myths or one of the issues. We also heard practical strategies from Don and Uma about, hey, how are we going to start moving people towards understanding these extremely complex, non-commonsensical sometimes, rules and regulations, when all we really want to do at the heart of things is make sure that we're starting to have information exchanges in which we're actually doing a better job of reaching human outcomes. So the panelists described, the tensions between things. I won't talk about that, but I will say, in terms of the international perspective, it's quite interesting that the United States is one of the few nations that does not have privacy rights written into its constitution. I find that really interesting. Privacy rights on an international level are considered a fundamental human right. And I know my friend Mary makes fun of me when I say that, because she says, oh, yes, everything's a human right to the international community. Well, okay, yes, and what's wrong with that? The what-if girl, right? What's wrong with that? That's great. But, funnily, in most of the rankings, international rankings, like in many other areas, the United States actually comes out quite low. And in terms of statutory protections, because we have no nationally cohesive privacy policy, we do not have it written into our Constitution, we rank very low in international rankings in terms of protection of privacy rights, which are fundamental human rights to the international community. we're the lowest because we have no, in terms of countries like, let's see, 25 EU countries, Australia, Canada. We rank between Thailand and, let me think of another one. We rank between Thailand and I think, I'm trying to think of another country. Well, I know that now we're even below South Africa, for example, right? Because they wrote in their new constitution privacy rights as a fundamental human right. So that gives you a sense of where we're at. Under the UN Declaration of Human Rights, the International Covenant of Civil and Political Rights, and many other international conventions, privacy rights are clearly articulated as fundamental human rights, which was again re-articulated recently in November when the Madrid Privacy Declaration came out. And they say the Madrid Privacy Declaration, global standards for a global world. That's kind of catchy, I guess. But their point was to really say, wow, we have unaccountable surveillance activities going on, right? Governments are performing surveillance activities now that we have no accounting for. There's growing collaboration between government and vendors of these surveillance technologies. There's growing consolidation of internet-based services. As I think was touched upon earlier, there's a failure to safeguard privacy that people are beginning to suspect our personal data has no independent oversight, whether that is addressed now by the HITECH Act when we didn't even know that our privacy rights were being violated. We didn't know our information was being shared. And so there's a lot of stuff going on that we don't even realize. And the question raised by the Madrid Declaration is really, can we sustain democracies, constitutional democracies, if we continue to erode the privacy protections that we have in the world? Funnily, I think I was an English major in undergrad. So I love George Bernard Shaw, and I love his quote, an American has no sense of privacy. He does not know what it means. There is no such thing in the country. So he said that over 150 years ago, and I think that now it's true. I was startled to learn recently that more young people applied to be part of MTV's Real World than applied to Harvard. Right? So I want somebody surveilling my everyday life, every move I make, every interaction I have. I mean, reality TV is, in a sense, a surveillance activity that now we've popularized as entertainment. So there's we all know that the younger generation seems to have a very different expectation of privacy than what we have, right? There's the social networking from Facebook, Twitter, and there's some cases that are kind of fighting back, but we still have no cohesive privacy policy. In the United States, our privacy protections are based from seminal work by Brandeis in the 1890s, privacy in torts law, that is the right to be left alone. And so our common law has evolved into this complex maze of what we have today. And today the courts are trying to sort things out as some of these cases, for example, some of the sexting cases. I did hear in one of the end-of-the-year commentaries that now that's a passé word we're not supposed to use anymore, so we're going to have to come up with something else. But I'm sure you've heard about some teenagers that have been prosecuted and actually listed as sex offenders for sexting. And we have a New Hampshire nurse that has already filed alleging constitutional violations of her privacy rights because of the Recovery Act. A fascinating case that hopefully the Supreme Court has agreed to hear, and hopefully we'll have that ruling in June, is the Kwan case out of California. And at issue there was a police sergeant and actually a few other police officers that were using their employer-paid pagers, and they were sending sexually explicit personal communication to, I don't know who they were sending them to, but the Ninth Circuit actually said, hey, no, that is an unreasonable search under the Fourth Amendment, even though it was an employer-paid pager. So all of you people who are employers, listen carefully to this, because it could affect public agencies as well as private, that it is an unreasonable search because officers had a reasonable expectation of privacy, even using their employer-paid pagers to send sexually explicit personal information to others. So again, we're going to expect that ruling in June of this year. It ought to be interesting. It's completely self-evident to point out that that turbulence that Doug Ray was talking about this morning. This is a very fast-moving, turbulent time. I mean, we all understand that technology has so rapidly advanced that policy and law has not kept up with what's happened with technology. I was talking to a friend in the intelligence community the other day, and she was saying, we don't have anybody to hire anymore. There's no young people we can hire. Not a one of them can pass the security clearance because they've got all these, text messages and their Facebook stuff and everything else. And she's terrified they're going to have no one to hire. Whether that's true or not, I don't know. Maybe we're all going to have to loosen our expectations up. I found it very interesting. After President Obama's Nobel Peace Prize acceptance speech, there was a press conference, and that happened to be the day that the 5 Americans were arrested in Pakistan. I'm sure you recall that they had connected through social networking sites like Facebook with jihadists. And the president commented that the internet can be dangerous. And I thought, we're kind of wanting it both ways right now. We want everything technology can do for us as an enabler, as a tool. I mean, isn't that really how he got elected? In part, right? Use of the internet. And at the same time, he's saying, oh, no, but it's dangerous, that these people are connecting with nefarious others through these social networking sites. So that was kind of interesting. And last, just a comment, we all know that the national security issue is going to be heating up around body scans. So the privacy rights related to body scans. I joked with Jennifer, I'm like, well, body scan permitting, I'll be there at the conference. So we've got that to look forward to as well. And still, again, with no real advancement of looking at policy around privacy issues in some cohesive way in light of the technology era. Very quickly, fear factor, you've already heard some of it. You know it, right? I mean, I'll skip right to even or especially the lawyers, because we're kind of picking on the lawyers today. I recently was called in on a situation where they had a lot of lawyers in their room. It was a community college, large community college. One of their international students had been, he had contracted TB, or brought it with him from his home country from a visit. And he was absolutely adamant that none of his personal health information be provided to anyone outside of the hospital. Of course, this is a public health issue, which is an exception under HIPAA. But the hospital's attorneys had a certain stance. The college's attorneys had a certain stance. And mind you, I should say, this was during finals week. So they were going to be sending off all of these students. His roommates, his 3 roommates had already contracted TB. So, and the public health officials from the state, of course, have the money. They were going to come in and do testing, the secondary testing of even chest x-rays, everything for free for everyone. But they didn't know how to approach this. And every entity's attorney had some slightly different view. I mean, it is that fear factor around getting it wrong that has often driven us underground, right? We don't even want to ask the questions about whether or not we're getting it right. One, we fear that nobody even knows at the federal level, dare I say in front of Dr. Hunt and others. And 2, that they're going to tell us that even the risk-based decisions we've made in good conscience are absolutely wrong. We're terrified we're going to get that answer of, no, you have done it wrong. And I think that's why Uma emphasized, and she was very lucky to have an AG that was supportive in her work on this. But that fear factor is driving a lot of what we're doing. And Uma said it as well. I just want to touch on consumer-facing professionals. I mean, often, we can laugh about the lawyers saying no, or the leadership, management of not being willing to take risks. But it is worth repeating that at the level of the consumer-facing professionals, they have been well-trained that what their work is with their customers, whom they respect, that is confidential. And overcoming that cultural barrier, especially when you're making risk-based decisions where you really don't know the answer, that is a really challenging aspect of this problem. I think, I love this quote, the lacuna. If any of you, this is the latest Barbara Kingsolver book. You guys have to read it. I thought it was just a slightly nicer twist around the, go ahead and wait for the punishment, don't ask for permission. She phrased it a little bit differently. Penitence is more attainable than permission. And I think that that's absolutely right. And again, at the federal level, when we talk about interoperability, we wonder if there have been discussions across the federal departments, from education to health and human services, as to whether or not we can start getting some alignment between the privacy policies or actually have a cohesive approach. I'm going to skip on now. I've got the money slide, because we know that we've already heard a little bit, and we're going to be hearing more about all the health IT money. And I was really appreciative, actually, that the Agency for Health Research and Quality went out around the country last summer and did 20 different focus groups. Consumers have long not been a part of the dialogue. And on these focus groups, I think what was so critical about them was, number one, participants didn't even know that the federal government has put billions into health IT. So even to launch the focus group, where they wanted to find out about people's sense of health IT, they had to explain that it is a national priority, that by 2014 we're supposed to have all of our records in electronic form. So they're not even aware that that's happening. So once you jump past that hurdle, let me tell you a little bit about the results of the focus group. Privacy and security, not a surprise, were the main concerns of the large majority of participants. So now that all this money is invested into making this happen, now we go out and ask real people, and they say, oh no, I don't want you spending money that way, because I am terrified about my medical data not being private. And I hear every day about military laptops being lost and other, the security issues. So that was interesting. A very large proportion felt that they should be asked for their consent and authorization before even allowing electronic storage. So that's where this is really the public opinion baseline that builds upon polls over several years. So you can see that there is a tremendous gap between the driving of the federal resources towards health IT and what the public is thinking about this. They're back to, wow, I don't even want you storing my stuff electronically. They definitely wanted to specify authorization for release, to whom and under what conditions, not a blanket opt-in, opt-out. They didn't understand the process by which the federal government was making decisions concerning the design and use of health IT. And like many past polls, and I think I mentioned one or two in my primer article, so you can see them there, they really cited that distinct tension between, well, maybe my service providers could be more efficient. I'd actually like to email my doctors. I'd actually like to get some of my medical information because I think there are errors in it. I really want to control it. And at the same time, this overwhelming sense of resignation that, hey, I've already lost control of my medical data. I don't know it for sure. I don't have the proof, but that's the way I feel. And of course, then the worry about discrimination, stigma, other things that comes from that information being out there. As we say in my home state of Nebraska, the cow's already left the barn. And now consumers are being asked, well, what do you think? And it's like, oh, I had no idea. We were already this far along. The ONC's work, they did. Their business user case was called Consumer Preferences. And I was a little tongue-in-cheek in the primer article, but I'll just mention that all the policy issues around privacy were left as out of scope. And while I have not, like my colleague Jennifer, who spent New Year's Eve reading the 556 pages of the definition of the proposed definition of meaningful use. I mean, you got to give it to her that she did that. I asked her, I said, well, what was in there on privacy? Because all of the privacy advocates, the privacy watchdogs were saying, you have got to address privacy. I mean, we know that that is what patients are concerned about. Privacy and security, that must be addressed in the proposed definition for meaningful use. So since I haven't read it, I can't comment, but Jennifer says there's nothing in there on that. One of the foremost patient privacy rights groups really said we need it spelled out. First of all, they raise some of those niggling questions that we hate to think about sometimes. Number one, we have no healthcare system in the United States. Meaning that, it's based on personal encounter data that is an individualized choice, and even during that individualized choice of even having the encounter, the individual's choosing what to disclose. And so they argue, we've got to get this back to the consumer level, to the individualized choice and control. They cite that HHS's own statistics say that 2 million people avoid treatment for mental illnesses in our country because they know that their records are not private and they cannot control them. So that's already now, HHS says that. 600,000 avoid early diagnosis and treatment for cancer, which I was surprised about for the very same reason. Again, concerns over privacy. So they're arguing that, in fact, we can't have a nationally cohesive privacy policy. This really has to get to the individualized level. So that tension, again, between the collective and the priorities of our nation versus the individual rights that our country was really founded on, and trying to bridge that gap. I was talking with my colleague Eris before, and I was saying, well, what are we going to do when people are urging that we go out to consumers? One, they don't even know that the money's invested in health IT. Number two, when you talk about individualized decisions around what should be put in electronic form, what should be shared, we've got an issue, right? We've got 40% of Americans, and that may be a conservative estimate, that are semi-literate or do not have basic literacy skills. We know 42 million for sure don't have basic literacy skills. So are we ready and equipped to do the kind of education that we need using multiple strategies in order to actually get to that point of individual choice, which involves informed consent? It's a tough question about how we're going to go forward and do business. So where does that leave us? Well, I'm going to stop on the, back to the what if, right? So what if we are at a time when we can ask the really hard questions and we can expect to work through them, having a national dialogue? And I want to draw upon the brain power in this room and ask the what if question and a few other, what I hope will be thought-provoking questions. Is a nationally cohesive privacy policy possible? What would that look like? We've heard about how complex it is now, how overwhelming it is. So what would it look like if we had a cohesive privacy policy?